Hi, this is Sue. In this screencast, I will be talking about steps for starting an IV and also some special considerations and special situations. So first you select the site that you are going to be starting the IV in, and we talked about that in a different screencast. This picture shows the basilic, the medial, and the cephalic vein, and so you can see the anatomy. They're not always this easy to see, however. Once you've selected the site that you'll be using, you need to get your equipment together. And the first thing you'll select is the cannula size. They have different lengths and different diameters or gauges. They can be as small as 3/4 of an inch long, or as long as 1 1/4 inches or 1 1/2 inches. The gauge, similar to a needle on a syringe, the larger the number, the smaller the diameter of the needle itself. So for people with small veins, including children and the elderly, we would use a 22 to a 24 gauge catheter, and when we need a larger cannula, we can use a 16 to an 18 gauge. So that would be for a person that we knew was going to get a high flow of fluid or needed to transfuse blood very rapidly. You can transfuse blood in a smaller gauge, a 22 or a 20 gauge needle, but not as rapidly as you could with a large gauge. You always want to use the smallest size possible, given the purpose of the needle, and that's because the larger it is and the longer it is, it will rub inside the vein more and possibly cause phlebitis. So the picture in the bottom of this screen, you can see a 24 gauge is a very small diameter, whereas a 14 gauge is more like a garden hose. I also want you to look at the picture on the top at the very tip of the cannula. The white part is the soft, flexible cannula itself, and the needle is inside it. You can see it poking through. We need the needle itself to access the vein, to puncture the vein, but once we're in, the needle comes out and the cannula stays in. Other equipment that we will need, if they are getting IV fluid, we want to have that ready, the type of fluid. We need IV tubing. We need an IV pole and a pump if we're going to be using it. We need extension tubing with a saline lock on the end, and you can see a picture of it here. Sometimes they come attached, and sometimes you get the extension tubing and the saline lock separately and put them together. Then you select your needle and angiocath, and you will need a tourniquet, some antiseptic solution to clean the site, and a clear Tegaderm dressing to put over the site. And often those things come in an IV start kit all together, and if not, you need to gather that stuff. You need clean exam gloves to protect yourself, and you need a syringe of normal saline flush, to flush the IV once it's in. You also should have a stabilization device, and that depends on your facility, what they use. The picture at the bottom here with the blue plastic piece, that's called a stat lock. That's a common type used, but there are other ones. And we put that on after the IV is in to hold it stable so it doesn't wiggle around. And you will also want a towel or a disposable drape, something to go under their arm if you have blood so that you don't have a mess. Then you want to look at your vein, make sure that you know where it is, what direction it's going in. And so there's some things that you can do to help visualize the vein that will help you be successful. So when you put the tourniquet on, you want to make sure that there's enough tension to cut off the venous blood flow, but not the arterial. So if you look at the picture here and you see how that tourniquet is indented, that's about what you want to see. You can also use a blood pressure cuff instead of a tourniquet. Have the patient make several fists to pump the blood, and that will help dilate the vein. And use gravity. Position the vein dependently, so have their arm down. If they are in a chair, make sure there is something in front of the chair so they don't faint or fall out of the chair. If they're in bed, have them move to the side of the bed and dangle their arm down, and that will help. Also, hot packs. Some facilities have small hot packs that are made to put over veins to help them dilate so that we can see them. If you don't have those hot packs, you can get a warm towel and wrap that around their arm till the veins stand out. Another thing you can do is gently tap or stroke the vein, and that may help it stand out. You sometimes see people flicking the vein with their finger, with their fingernail, and the problem with that is, number one, it's painful, and number two, it can make the vein spasm. So stroking it and tapping it can help. Sometimes when you put the alcohol or the betadine, whatever you're using to clean the skin with, and you put that on and it's shiny, sometimes you can see the vein better. And make sure you have good lighting. If you're having difficulty seeing the vein, don't just use the overhead light, but use a gooseneck lamp or a lamp that you can position closer to the patient. And position yourself close to the patient. If you are bending over them to start it, your back will hurt and you're farther away. So raise the bed or have the bed in a low position and pull up a chair. Sometimes that's, especially when you're learning and taking more time, that's the best thing to do so that you're comfortable and close to the site. So the steps of the insertion itself. Assess the vein by feeling it. You can stroke back and forth over the vein very lightly to feel it. You're feeling for a bouncy little area there with hopefully some elasticity. Sometimes you can't feel it, and you need to know the anatomy and the location of the veins. If the vein is small, sometimes using an indirect technique is better than a direct technique with starting the IV. So with a direct technique, you are doing what the healthcare provider is doing in this picture. You're positioning the cannula right over the vein and puncturing directly into the vein. With smaller veins, you can actually puncture straight through the vein. And so an indirect method is where you puncture the skin right next to the vein and then slide the needle into the vein. And there's less chance of it going through the vein. With either technique, you need to stabilize the vein very well. Once you clean the site, don't touch it. That's also something I see people doing sometimes, and I cringe. They do a good job of cleaning the site, and then just to be sure that they know where the vein is, they put their finger on it and poke around to make sure they feel it. Well, now the site's not clean anymore. So make sure you know where you're going, and after you clean it, do not touch it. and I see people cleaning off the tip of their glove with alcohol. That's not acceptable. You shouldn't touch the site at all once you've cleaned it. How you clean the site depends on the policy of your facility, but generally you're using a back and forth friction rub of a 4x4 area. But look for the policy at your facility for how they want you to do it. And after you've cleansed it, you need to let it dry completely for the antimicrobial action to work. So just wait till it dries before you go ahead and pierce the skin. As I mentioned, you need to anchor the site with your finger so that when you put the needle in, the vein doesn't roll. And a good way to do that is what is happening in the picture here. You put your thumb distal to the site that you're going to be puncturing, put some pressure down, and pull towards you, and that will hold the vein in place. You have to be careful that your thumb is far enough away from the puncture site that the cannula doesn't rub up against your thumb, because then it wouldn't be sterile anymore. Look at the bevel of the needle and make sure that when you go in, the bevel is up. And the angle that you're going in depends on the patient. If the vein is close to the surface, like in this picture, you want the angle of the needle to be very small, a 10 or 15 degree angle. If you have a deep vein, or a patient who's obese, or a patient who has edema, you need to go at a larger angle, maybe a 30 degree angle, to get into the vein. And that can be more challenging. You go in till you feel what I'm calling a pop, but it really isn't a pop that you hear or feel very strongly. It's more of a sensation of giving way. You're pushing the needle in, something gives way, and then it glides in easier. Once you get that pop, you want to look for what we call a flash of blood in the cannula, and I'll show you what that looks like. Then once you're in, you decrease the needle as flat as you can, and then you advance the needle another 1/4 of an inch, just a small amount, and the reason for doing that is you will get that pop and you will get the blood flash or the blood return when the needle punctures the skin, but that doesn't mean the cannula has gone into the vein yet. So you need to advance the needle with the cannula just a little to make sure the cannula is in the vein, and then you hold the needle steady and advance the cannula. You can do it with a finger like this nurse in the bottom is doing, or now that you're in the vein, you can let go with your non-dominant hand, the one that's been pulling back the skin and stabilizing. You can let go now, and you can use that hand to advance the cannula while the other hand is anchoring the needle. Once the needle has gone in that little bit, you don't want to advance it any farther, or you may go through the vein. Once you have pulled the needle back, don't ever advance it again. So you've advanced it a little, you're drawing the needle back, and you don't think the cannula is in all the way, never push the needle forward again. You could injure the inside of the vein, or you could actually pierce the cannula itself. So the picture on top is an angiocath with a little chamber that has blood in it, and that's what we call the flash, where that little chamber fills with blood so that you know you're in a vein, and you want to watch for that. But again, that doesn't mean the cannula is in the vein. It may only mean the tip of the needle. So once you see that, advance another 1/4 of an inch. When you see that, release the tourniquet. Back up. Once you see the flash, advance your cannula and release the tourniquet before you remove the needle. If you forget to release the tourniquet and you remove the needle, you will get a gush of blood through the cannula, and it'll be a mess. You won't hurt the patient, but it's not fun. So release the tourniquet at this point. Hold finger pressure over the catheter tip. So if you had a 1-inch angiocath or cannula, picture where that 1 inch is, put pressure over the vein there, and then release the needle, and that will help minimize blood. Most needles now have safety releases where the needle is pulled into the device itself so that there's no danger of you sticking your finger. So remove the needle or retract the needle. Quickly attach the extension tubing and flush it with saline. Once you have done that, put your stabilization device on, whether it's a stat lock or another device, and then place your dressing over it. And that's the picture below on this screen. You want to label the site, and either there are labels that you can put over the tegaderm, or sometimes nurses will take a Sharpie and mark the dressing, but don't go near the site of the insertion. You want to be able to see that so that you can see if there's any complications. You also, if they're going to be hooked up to an IV, you want to label the IV tubing. 2 labels, as we learned, one near the drip chamber and one near the bottom of the tubing where it's going to be attached to the patient. The dressing should go up to the hub of the cannula, but not over it. You want to be able to remove the extension tubing if you need to without having to take the dressing off. Use of local anesthetics. That would be nice if we had a local anesthetic so that the patient doesn't feel when we're putting the needle in. And sometimes we have a policy where we can choose to use a local anesthetic. There are some creams that you can use. Those have to be put on about 30 minutes prior to starting the IV, so that's not always feasible. Or there's 1% lidocaine. Some of the drawbacks of using an anesthetic, well, the cream you have to wait, and sometimes the patient needs the IV in now. The lidocaine, if it's not buffered, it can be as painful as the needle stick to put that in, so you're not really gaining anything. We can buffer the lidocaine, but then it will only last for 24 hours in the container. So if it's a multi-use container, that wouldn't work. Also, when you put the lidocaine in, you cause a bleb, and so sometimes once you've put that in, you can't see the vein anymore. So find out what the policy is at your facility. See how comfortable you are with the vein, how well you can see it and feel it, and then make a decision about using an anesthetic or not, keeping in mind that you need to make sure you have an order and you need to make sure that the patient is not allergic to it. And this is a picture of what it should look like when it's placed correctly. There is a saline lock on the end, an extension tube, a securement device. There's a clear dressing over it, and it's secured well with some kind of tape there so that it doesn't move around in the patient's veins. And these are just some pictures I'm going to show you that shows how the needle goes into the vein. So you pierce the vein with the bevel up and watch for a flash of blood. When you see that blood return, you want to change your angle, bring it back down to as close to the level of the skin as you can, and advance it another 1/4 of an inch so that you know that the cannula itself is in the vein. Once you've done that, you can pull the needle out. They call that hooding the stylet. Generally what we'll do is hold the needle stable where it is and advance the cannula into the vein and then remove the needle. But once you are that 1/4 of an inch in, you need to hold the needle and make sure that it doesn't go in any farther. Some common problems that can get in the way of having a successful start. One is using a very tentative start and stop technique. So you're nervous, you go in a little, you stop, you go in a little more, you feel around for the vein. That's not a good situation. You want a nice smooth entrance. Inadequate vein stretching, where the vein, you go to insert your needle and the vein actually gets pushed to the side. So you need to make sure that you've got your thumb over the vein and you're pulling it tight towards you before you puncture the vein. Stopping too soon after insertion. Remember, when you see that blood flow, you need to go in another 1/4 of an inch. Otherwise, the needle's in, but not the cannula. An improper insertion angle. If you're too steep, you will go through the vein. If you're not steep enough, you won't get into the vein. And this is one of those things that it just takes practice and experience to get a feel for the angle that you need. Know the policy for how many times you can attempt to start before you have to give up. Most facilities will say 2 attempts by 1 practitioner. Some say 3 attempts total between 2 practitioners. It depends on the policy. But a good rule of thumb, if you don't have a policy, is you should not attempt more than twice on the same patient. Get help if you're not able to get it in twice, and know your policy. Documentation guidelines. Well, in the electronic health record, there is usually a screen where fortunately we just check things off and that will remind you what you need. But typically what needs to be documented is the date and the time it was inserted, the type, so angiocath, the length of the cannula, the gauge, the number of attempts that you made, which side, right or left, and the location. Often they will have a picture of an arm with numbers over the different veins, and you put in the number of the location, the type of solution you hung, if you did, and the rate, the condition of the site. Is it red? Is it swollen? Is it painful? And as I mentioned, we label the dressing. Usually it's your initials, the date and time, sometimes the gauge of the cannula, and the IV tubing you label in 2 places. And then we need to document any follow-up assessments. Typically, we are required to assess the site every 2 hours. Depending on the fluid, or if it's a child, we may be assessing the site every 1 hour. We need to document if we change bags of solution, if we change tubing. We need to document that, and of course any complications that we see. Some complications from the IV insertion would be infection, and there is no reason for that. If we've done it correctly, that is absolutely operator error. If we nick the vein or go through the vein, we could cause a hematoma, And you will see that right away if you go through the vein, that it will start turning blue and bubbling up a little. If that happens, pull the needle out and put pressure on the site. We could cause nerve damage, but again, if you stay away from the radial vein, there's much less chance of that happening. And you could hit an artery, although except in the antecubital, they tend to be pretty deep. Some challenging situations. The elderly often have less subcutaneous tissue, like this hand in this picture, so you need to anchor the vein very, very well. Because the skin is loose, you need to anchor the vein very well before you pierce the skin. And you may need to anchor it above and below the site that you're going to put the cannula in. So you use your forefinger and your thumb and you spread the vein. You want to use a very low angle of insertion, as you can imagine, and you want to be careful with the tourniquet because you can cause skin damage. So be very careful with how tight you put it on, and you may choose to use a blood pressure cuff instead of a rubber tourniquet. Pediatrics are a challenge for many reasons. Their developmental age, their intolerance of pain, the size of their veins. So I'm not going to talk a lot about starting on peds. If you have a pediatric patient and you're not on a peds floor, find a nurse that's worked with pediatrics before. Keep in mind their developmental stage so that you can approach them, and go to a neutral area to start the IV. Their room should be a safe place as much as possible, so take them into an exam room or somewhere else to start it. Distraction is good, and often we need to use an arm board, not just because it's in a positional area, but so that we can dress it or tape it up really well so that curious hands can't get at it. And you'll learn more about IVs in pediatrics when you get to that course. Patients who are obese and patients who have edema present a challenge because we may have difficulty reaching the vein. What you want to do is displace as much of the tissue as you can in looking for the vein. So you may need help. You may need another person to help pull the skin and the extra tissue to the side. You may want to use two tourniquets, one above and one below the site, to help it dilate and fill up with blood. Find the site, mark it with a sterile pen if you can, or you can use the tip of a pen to mark it, not with the ink but with the plastic. But do that before you clean it, and that helps guide you where you're going to insert. If they have edema, you want to be very careful with tape to prevent increasing the edema. You don't want to make it worse. And of course, you're going to select a longer needle to be able to reach the vein. Other challenging situations are diabetics. Because of poor circulation, you may have to go more proximal to find a larger vein. Patients who have used steroids for a long time, their tissue can be more fragile and they can bruise easier. And anybody with a bleeding dyscrasia or a bleeding disorder, or who is using anticoagulants, is more prone to hematomas. Women in labor are often challenging because they are often stressed and maybe in pain, uncomfortable, and that causes vasoconstriction. Also, because they may be using their arms and moving around a lot, we need to make sure that it's anchored very well so that it doesn't become dislodged. Confused or combative patients, you may need assistance to be able to get it in. So make sure to get as many people as you need, and if it really is a safety issue, you want to talk to the provider about that. And then lastly, I want to talk about fearful patients or patients that have needle phobias. First of all, if your patient says he's afraid of needles, believe him. About 20% of adults have a mild to moderate fear of needles, and about 10% of adults have such a profound fear that they have clinical symptoms. They can have a vasovagal response where they become bradycardic, hypotensive, they vasoconstrict, they can pass out. It's a physiologic response. If you ask them, they will say it's not the needle or the pain so much that they're fearful of. It's a sensation of having something entering their body. So acknowledge their feelings, be very supportive and gentle. If they've had an IV before, ask them what works best. Distraction is good. If they have a friend or family member there, have them talk to them and distract them. Music, conversation, talking to them while you do it. Having them do slow, relaxing breaths can be helpful. And be careful of the words you use. You don't want to say, it's not a very long needle. You can say that it's a cannula. Don't say, I'm going to stick you or poke you. You can use the word insert. So you can say, I'm going to insert a soft cannula or tube, and only the soft tube will stay inside your vein. Make sure they're positioned safely, so supine, and that would be a good opportunity to use a local anesthetic, if possible. There are some good articles that are up on D2L about starting IVs in difficult situations like the ones I've talked about, so you will want to look those over. And remember that starting IVs can be a challenging skill to master, and it may take several attempts before you have enough experience that you feel confident and can be successful. I've talked to students that are successful on their first try, and I've talked to students that have had to do it many times before they've been successful. But just like anything else, you practice, 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 gain experience, and you will become confident and successful, I promise.